This is microcircular. So bowel obstruction is also known as intestinal obstruction, and it's a blockage that prevents the normal movement of food and fluid through the intestine. It can occur in either the small bowel or the large bowel. Hence, we have small bowel obstruction and large bowel obstruction. Bowel obstruction may be complete or incomplete. Complete obstruction means that no fluid or gas can go beyond the incomplete or partial obstruction means that fluid or gas still flow in the anatomy review. The abdomen is the part of the body that contains all the structures between the thorax, which is the chest, and the pelvis, and it is separated from the thorax via the diaphragm. The region occupied by the abdomen is called the abdominal cavity. By right, you can see an image that literally separates the thoracic cavity from the abdominal cavity. Quadrants and regions of the abdomen. There are 4 quadrants of the abdomen. These are imaginary lines that are used as landmarks in describing and positioning. There are 2 planes which divide the abdominal pelvic cavity into 4 quadrants. So we have the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. Also, the images are attached like the slide. We have regions of the abdominal pelvic cavity can also be divided into 9 regions through the use of 2 horizontal planes and 2 vertical planes. The 2 horizontal planes, that's this, they are called this is the transpyloric plane and this is the transtubercular plane. So they divide the abdomen into 9 regions. The right hypochondriac region, the epigastric region, the left hypochondriac region, the right lumbar, umbilical, the left lumbar, the right inguinal region, the hypogastric or pubic region, and the left inguinal region. And here we also have an X-ray image that explains, that shows us the division of the abdomen into 9 regions. Moving down, we have overview of the relevant anatomy. So we have the small intestine. It said it is centrally located and it is approximately 6.5 meters in the average person. It aids in digestion and absorption of ingested food. It extends from the pylorus of the stomach, which is somewhere around here, to the ileocecal junction where it meets the large intestine at the ileocecal valve. Anatomically, the small bowel can be divided into 3 parts. We have the duodenum, the jejunum, and the ileum. The duodenum is the first portion of the small intestine. It is the widest, and when filled with contrast, it has a C shape. Looks like a letter C. The jejunum and the ileum, they lies in the central and lower abdomen. Then we have the large intestine. The large intestine is the distal part of the GI tract. It extends from the cecum to the anal canal. It receives ingested food from the small intestine, where it absorbs water and electrolytes to form feces. The colon can be divided into 4 parts: the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. The ascending colon, it continues from the cecum and moves upward where it meets the right lobe of the liver. So somewhere around here, it forms the hepatic flexure and moves horizontally, forming the transverse colon. Now, the transverse colon meets the spleen and forms the splenic flexure and then descends downward, forming the descending colon. Then the sigmoid colon is the continuation of the descending colon and it's located in the left lower quadrant, where it continues to the rectum and anus. So we have an image that shows us the large intestine filled with contrast. This is a barium animal study showing the large intestine. The first part is cecum, then we have the ascending colon, then C is the hepatic flexure, D is the transverse colon, E is the splenic flexure, F. Descending colon, and sigmoid colon and rectum, as labeled there. Types of bowel obstruction and their causes. So we have two types of bowel obstruction. We have mechanical obstruction and functional obstruction. Mechanical obstruction is the most common type of bowel obstruction, and it is caused by physical blockage in the intestine. It can be due to things like adhesion, hernia, tumor, foreign body, fecal impaction, or volvulus. Adhesion is scar tissue that forms after a surgery. Hernia is a weakness in the abdominal wall that can allow a portion of the intestine to protrude through, creating a blockage. We have tumors. These are growth in the intestine that can block the passage of food and fluid. We have foreign bodies, coin, keys, batteries that can be swallowed and become lodged in the intestine. We have fecal impaction, like a large mass of hardened stool that is refusing to move out, can cause obstruction. Volvulus, which is twisting of the abdomen along the mesentery. And we also have intersection, which is a medical condition in which a part of the intestine folds into the section immediately ahead of it. And it is common in children. It typically, most times, involves the small intestine and less commonly involves the large intestine. So here we have an image that shows intersection. We can see a bowel. And then we can see another one, we can see two of them inside. Then we have functional obstruction. This type of obstruction is caused by a problem with the muscles of the intestine. It prevents them from contracting normally. And it can be due to a condition like paralytic image, which is a temporary paralysis of the intestine that occur after surgery or due to certain medical conditions or certain medications. Etiology of bowel obstruction. So small bowel obstruction are usually caused by adhesions, hernias, or malignancy. Large bowel obstruction are usually caused by cancer, volvulus, or diverticular disease. Role of imaging in the diagnosis of intestinal obstruction. Imaging plays a crucial role in the diagnosis of bowel obstruction by helping to confirm the diagnosis, that is, distinguish between a true mechanical obstruction or another conditions, localize the obstruction, pinpoint the specific area of the bowel where the blockage is occurring, identify the cause, determine the underlying cause of the obstruction, such as tumor, adhesion, or foreign body, assess for complications like ischemia or perforation, guide treatment. It helps to determine the appropriate treatment if it's going to be surgery or conservative management. Imaging modalities for diagnosis of bowel obstruction. Plain radiograph. This is also always the first imaging modality, and it can show dilated bowel loops and healthy air fluid levels. CT scan is the most accurate imaging modality as it provides detailed images of the abdomen and pelvis, helping to identify the cause of the obstruction, location, and it's also useful in diagnosis of bowel obstruction caused by tumors and adhesions. Ultrasound can be helpful in certain situations, especially in pregnant women or children. However, it is limited due to its image quality. Diagnosis is usually done using the 369 rule. That is, the diameter for the small intestine should not exceed 3 cm. Diameter for the large intestine should not exceed 6 cm. And the diameter for the sacrum should not exceed 9 cm. Magnetic resonance imaging can also be used in some cases, especially when other imaging modalities are inconclusive. MRI is prepared for pregnant women with bowel obstruction that is suspected to be caused by adhesions. So ultimately, the patient clinical presentation, the suspected cause, and the availability of resources are part of the things that determine the modality best. So here we have the image of different modalities. We have first of an X-ray imaging showing air fluid levels and dilated bowel loops. We have this showing An obstruction here due to a mass, we have an ultrasound image showing the small intestine measuring greater than 3 cm, and then we have an MRI image. Difference in appearance between small bowel and large bowel obstruction. Between small bowel and large bowel. So the small bowel is centrally located while the large bowel is peripherally located. The small bowel has lobular conniventes, which are thin circular folds of mucosa that appears to be like a line crossing the entire lumen. They create a spoiled spring appearance, while the large bowel has haustral markings, which are almost similar to the lobular conniventes, but the difference is they do not form ring-like. They do not completely encircle the lumen. They create a segmented or pouch-like appearance. The diameter of the small bowel is normally less than 3 cm, and that of the large bowel is normally less than 6 cm. Common site for bowel obstruction. Bowel obstruction, the site for bowel obstruction depends on the cause of bowel obstruction. Bowel obstruction due to adhesion. Adhesion can occur anywhere in the abdomen. However, they are most likely to cause bowel obstruction in the small intestine because the small intestine is more mobile than the large intestine, and therefore are more likely to become twisted or keyed for an adhesion. Foreign body. The site of the obstruction will depend on the size, shape, and nature of the foreign body, because it can get stuck in the pyloric valve, it can get stuck in the cecal valve, and it can also get stuck in the large intestine if they are too large or too hard to pass through the rectum and anus. Tumors. The specific site of the obstruction will depend on the type of tumor, its size, and location. However, the colon is the most common site for obstruction due to tumors, because the colon is where most water is absorbed from the stool. Intussusception. The common site for intussusception is the ileocecal valve, which is located where the small intestine, which is ileum, meets the large intestine. In this type of intussusception, the ileum slides into the colon. So the small intestine slides into the large intestine. Fecal impaction. The most common site for fecal impaction is the rectum, because the rectum is the part of the large intestine. The feces at the rectum has most likely all the fluid have been absorbed, so it can make it difficult for larger particles to pass through. The volvulus is mostly occurs in the sigmoid colon, and it gives a coffee bean sign, and indicates sacrum where it gives a rounded comma shape too. Functional obstruction is common in the small intestine. This is because this is where digestion and absorption of nutrients takes place. And then if the muscles are not contracting properly, food can build up in the small intestine. Indications for abdominal X-ray: abdominal pain, vomiting, constipation, abdominal distension, and suspected perforation. So clinical features of abdominal X-ray. For clinical features of bowel obstruction, for small bowel, vomiting may be early and profuse, while for large bowel, vomiting may be late onset and less profuse. For abdominal pain, for small bowel, it may be colicky. Colicky is a type of pain that comes in, it's sharp, and then stays for a while and goes. While for large bowel, it may be cramping. Cramping is a pain that it ascends, it starts slowly, and then the pain increases, and also when it's going, it reduces slowly. It does not just stop at once. While colicky pain starts once and stop at once. So constipation may not occur in small bowel obstruction, while constipation occurs prominent and early in large bowel obstruction. Abdominal distension is less pronounced or less significant in small bowel obstruction, while it's more significant in large bowel obstruction. Bowel sounds for small bowel obstruction is early and high pitched, and for large bowel obstruction it may be less prominent. So patient preparation for abdominal X-ray. Patient is greeted and the procedure is briefly explained. You explain to the person what you need to do and how you expect the person to be. So you remove all clothing and any opaque objects in the area to be radiographed. So the patient is asked to remove his address and change into the hospital gown. Also, piercings like liver piercings should also be removed. Socks and shoes may remain on the feet. So basic views, we have AP erect and AP supine. Supplementary views, lateral decubitus. Essentially, the erect radiograph is taken first if possible. This is to visualize air fluid level within the dilated lobes of the bowel. So the rationale behind this is that gravity allows fluid to settle below gas within the extended bowel segment. So this creates an distinct air fluid level that are characteristics of bowel obstruction. Radiographic technique, AP erect. Patient stands with their back against the image receptor. While standing, the patient's legs are placed well apart so that a comfortable and steady position is adopted. The medial sagittal plane is adjusted to the right angles and coincides with the midline of the body. Pelvis is adjusted to ensure that there is no rotation. The upper end of the image receptor is positioned at the level of the middle body of the sternum so that the diaphragms can be radiographed. The collimated horizontal beam is directed so that it coincides with the midline, with the center of the image receptor in the midline. And exposure is taken on full expiration. This is the positioning for AP supine. Patient lies supine on the imaging table. Medial sagittal plane is adjusted to be at right angles. Pelvis is adjusted so that the axis is equidistant from the tabletop. Then if the cassette is placed longitudinally, it is positioned so that both below the symphysis pubis is included and also the diaphragm is also included on the image. Central beam centered at the midline of the image receptor can be directed towards the lower costal margin. This is to include the lateral margins of the abdomen, and exposure is also taken on arrested expiration. So this is the position for lateral decubitus, left lateral decubitus. So the projection is used if the patient cannot be positioned erect. It is to confirm the presence of subdiaphragmatic gas. It may be used for confirming a bowel obstruction. When the patient is lying on the left side, free gas will rise to be located between the lateral margin of the liver and the right lateral abdominal wall. To allow time for the gas to collect, the patient should remain lying on the side for a short while, for at least 10 minutes before the exposure is made. Lateral decubitus. The patient lies with lateral on a radiolucent pad on the left side. A 35/43 or centimeter cassette is supported vertically against the person's back. Then the collimated horizontal beam is directed to the anterior aspect of the patient and centered to include the field of view. And marker or arrow is placed to show the upside or the downside. Now here we have an image of left lateral decubitus showing free air in the abdominal cavity. So technical factors, of course, selecting factors should be due to your machine's output, but essentially 70 to 80 kVp, 32 mAs, and 35/43 centimeter cassette should be used. Essential image characteristics, it should include from the diaphragm to the symphysis pubis. The bowel pattern should be demonstrated with minimal sharpness. The lateral sides as display should be visualized on both sides. There should be no movement of sharpness and no evidence of rotation. No active parts such as belly piercings or necklace should be seen. And the radiograph should be quickly experienced. Imaging features of bowel obstruction. So we have air fluid levels. In bowel obstruction, multiple air fluid levels are seen in a stepladder pattern, indicating that different groups of bore are filled with varying degree of gas. So we have here where we can see X-ray levels around there. And also we have dilated bowel loops and absence of gas in the colon. So in the normal X-ray, gas is usually visible throughout the intestine, including the colon and the rectum. In large bowel obstruction, there may be lack of gas in the colon and rectum due to the blockade that is preventing gas from passing through. Also, we have the stream of Bell sign, and this is in a small bowel obstruction. It appears as small pockets of gas that is trapped between the fold or the intestinal, between the fold of the intestinal lining, resembling string of pears. So, string of pears is a feature that is seen in small bowel obstruction. Differential diagnosis: paralytic ileus, constipation, fecal loading. Limitations of X-ray imaging in diagnosis of bowel obstruction. So we have the issue of sensitivity. X-rays may not detect partial or early obstruction, as the changes in bowel dilation may be subtle. Difficulty in visualizing certain areas. So distinguishing causes: X-rays often struggle to pinpoint the exact cause of the obstruction, such as adhesions, tumor, or globules. It can be difficult to differentiate between the types of obstruction, which is if it's mechanical or functional on X-ray image. Image quality: gas pattern may sometimes obscure underlying structures, making it difficult to interpret the image accurately. Patient factors like large body habitudes or patient movements can affect the quality of their diagnostic, the diagnostic quality of the image. X-ray provides 2D image of the abdomen, which does not reveal detailed information about the bowel wall, surrounding tissues, and potential complications like ischemia or perforation. Role of the radiographer: the radiographer plays a crucial role in abdominal X-ray imaging for patients with suspected bowel obstruction. Their responsibility go beyond image acquisition. They're responsible for accurately positioning the patient and radiation protection. If possible, gonal sheet can be used for males as long as the gonal sheet used does not obscure the anatomy we are interested in. Immediate image quality assessment. So a radiographer's duty to, after taking an image, check, oh, is this image okay? Is there anything I could have done better? Is there a way to get a better image? Then is also responsible for ensuring patient comfort, and then performs communication to the radiologist in case of critical findings. Like if it's suspect that there's a perforation, you can communicate with the radiologist to maybe have a second look on that and then do an APRX to confirm the going out. And then his main responsibility is to ensure the image produces optimal diagnostic quality. So that's all. Next, we have study images. We have the CCL presents with spine and abdominal distension. We have this image here that shows dilated bowel loops. As you can see here, we have the bowel gaping basically, and you can tell that it's from the is a small bowel because it's centrally located. And here we also have it in highlighted row so that we can see it. And we also have here, where we can see the large bowel loop. You can see from the ascending column to the transverse to the descending column is dilated, and there is gas within it. You can also see the haustral marking, and then we can see that it's very located. Confirm that it's a large bowel. Here we see the coffee bean sign, that is an example of there is a sign of sigmoid volvulus. You can see it here, and you can see it here being highlighted for us. Then we have fecal impaction, a huge volume of fecal matter extending from the pelvis to the left upper quadrant. This can cause distension and inability to pass fat. So we can also see here, you can see a light going higher. Then here we can see foreign bodies. These are just images showing us different foreign bodies. You can see this looking like this is a coin, knife, battery. There's a blade. This is a ring, a pendant. This is razor. These are multiple nails. This is a kind of forceps as aestheticians use. This is hairpin, and these are pegs. And also here we have tubular shaped soft packets, soft tissue packet projected all over the abdomen, most likely drugs. So we have here, there are also parts of foreign body that can be ingested. Here we have an after-shaved bottle that has been inserted into the rectum. Here we have mobile phone. So in conclusion, abdominal X-ray imaging plays a crucial role in the initial assessment of suspected bowel obstruction, although it has limitations in sensitivity and specificity compared to other modalities like CT. It remains valuable due to its accessibility, speed, and lower radiation dose. Radiographers' expertise in patient positioning, technical factors, and image quality is essential for maximizing the diagnostic yield of X-rays. Ultimately, the information gained from abdominal X-rays often guide further investigations and treatment strategies for patients with bowel obstructions. These are the references. Thank you for listening.